The following podcast is part of a certified educational activity titled Addressing the Unmet Needs of Patients with Moderate to Severe Psoriasis, a visual exploration of disease pathogenesis and the clinical potential of targeting the TYK2 pathway as a novel nonbiologic oral therapeutic option. Access the entire activity and complete the post-test at peerview.com/NJS860. Downloadable infographics are also available.
Welcome to everyone who joined in today to hear this talk. My name is Andy Blauvelt. I'm a dermatologist and president of Oregon Medical Research Center in Portland, Oregon. Today I have the exciting news to tell you about the JAK-STAT pathway and in particular TYK2 signaling in psoriasis. We're going to talk a little bit about the background of psoriasis and the current therapies available and some of the unmet needs for this disease. Then we're going to go into some basic immunology of psoriasis, what's happening within tissue, and then we're going to focus down on JAK-STAT signaling, and then even focus further on TYK2 signaling, which is one of the members of the JAK family. And then finally, we're going to end with some clinical trial data on TYK2 blockade within psoriasis. So if we start first with the disease, so most of you know psoriasis. It affects more than 8 million Americans. Very common disease. It's a chronic immune-mediated disease. We know that the immune system drives keratinocyte activation and proliferation within lesions. And this is the reason why we've seen therapies target different pieces of the immune system within psoriatic lesions. Patients have prominent skin signs, as we all know. They also have prominent symptoms related to their disease with a big impact on their quality of life. So when we think about the thresholds of psoriasis severity, typically we talk about mild, moderate, and severe cases. These days, there's some new definitions out there about placing patients in just two categories: candidates for topical therapy or candidates for systemic therapy. To me, this is a little bit easier than mild, moderate, and severe, and this is what we're doing when we see patients. We're really looking at them and saying, is this a patient that we're going to manage topically or systemically? We have different scores for severity, of course, so you know those, body surface area involved, the PASI, and we have a variety of measures of quality of life with the DLQI, the Dermatology Life Quality Index, as being one of the main ones to measure the impact of quality of life on psoriasis. And we also know recently that the BSA is not the whole thing. So I say that because many of us think of body surface area of 10 or more as being candidates for systemic therapy, and we stop there. And I really encourage you to kind of go away from that because we do have patients with lower body surface area counts where disease may be in special areas such as the genital area, the palm and sole, the face, where the quality of life impact is great. And really, that's kind of why I like to see patients as either candidates for topical or candidates as systemic. And in that candidate for systemic, we have BSA as one criteria, but then we have the other criteria of where the disease is and how much of an impact it has on their quality of life. Now, another big thing in psoriasis that we know about is comorbidities. And this is just a reminder slide, examples of extracutaneous disorders linked to psoriasis, just to be a constant reminder for you that these patients don't just deal with cutaneous psoriasis. The dominant one here that we all know about is psoriatic arthritis, and this occurs in up to 1/3 of patients. And then the most important one, perhaps, for patients, I think, is the risk for cardiovascular disease because it can lead to death. So a higher rate of heart attacks, a higher rate of strokes in patients with psoriasis. That is a higher risk depending on the extent of the skin lesion. So we see patients with more widespread psoriasis being at greater risk for heart disease and stroke. But there's a wide variety of things other than those two that I highlight. But those are kind of the two main ones that I talk to patients about. The most common thing, psoriatic arthritis, and then the most deadly thing, heart attack and stroke. This is showing the basic overview of the pathophysiology of psoriasis. Now, this is a simplification, obviously. Pathophysiology of psoriasis is complex. We have keratinocytes involved in the epidermis. We have immunocytes or white blood cells involved in mainly the dermis, but also within the epidermis. And here we see over on the left-hand side, macrophages, plasmacytoid dendritic cells. So in general, we think of dendritic cells as more upstream to the T cell component because dendritic cells and macrophages are antigen-presenting cells that activate T cells. And with psoriasis, we know now that the dominant T cell type are Th17 cells, or if it's a CD8 positive T cell, it's a TC17 cell. And these cells are named that way because they make interleukin 17 as their dominant cytokine. So interleukin 23 and interleukin 17 have become dominant cytokines to target in psoriasis. And so many of the biologic therapies we have for this disease do that indeed. They do target those particular cytokines. Now, biologics in general are efficacious and well tolerated, but there are some limitations to these drugs. For example, some patients do not respond. They're primary failures. We also see patients who initially respond but then experience loss of response over time. And this is often due to immunogenicity, so the development of anti-drug antibodies that impair responses over time. The drugs are also given sub-Q or IV, so basically they require a needle to be involved. And then I think lastly, the biggest issue, at least for my practice, is the cost of these therapies. We see payers, for example, putting barriers to the use of biologics because of their high cost. So that takes us to alternatives to biologics, and that would be small molecule drugs for psoriasis. So small molecule drugs can be given orally or topically. So if we look at the conventional therapies, we are talking about now acitretin, cyclosporin, and methotrexate, our good old friends. So those drugs, as we know, have a number of drug-drug interactions and toxicity that requires blood test monitoring. So they have quite a few limitations to our older small molecule drugs. In recent years, we've seen apremilast come forward. It's a phosphodiesterase 4 inhibitor approved for moderate to severe psoriasis. But the problem with apremilast is the efficacy is very limited. So we still see, if we look at this group of drugs, we see the older ones with safety issues, and we see apremilast with efficacy issues, kind of opening the door or creating a need still for a novel oral therapy that is both safe and efficacious for psoriasis. So that takes us to the JAK-STAT signaling pathway that I mentioned at the beginning of the talk. And I told you this was going to be the focus because the agents that I'm going to be talking about are targeting different aspects of the JAK-STAT signaling pathway. So what is this pathway? Here's a scheme, if you will, pretty simplified scheme, and I like it because it's simplified. We have the cytokine, and cytokines are extracellular proteins. They're circulating outside of cells, but for them to cause damage or inflammation within tissue, they need to bind a receptor. And we see here, it looks like two hands reaching out is the cytokine receptor. And when the cytokine binds its cytokine receptor, what happens? So I call this like a relay race, and we're talking about a baton being transferred from the outside of a cell to the inside of the cell. And the cytokine receptor has an outside surface and it has an inside surface, as you can see here. And what happens is that when we have binding on the outside of the cytokine, we get a transformational change in the cytokine receptor on the inside of the cell, and that's usually through phosphorylation of the inside portions of the cytokine receptor. And what that does is allows JAK proteins to come and bind that portion of the cytokine receptor. So this is part of activation. And then phosphorylation occurs of the JAKs. And then along comes STATs, a different set of proteins that bind phosphorylated JAKs. The STATs become phosphorylated. They break off and they go to the nucleus to lead to transcription of pro-inflammatory mediators. So this is a relay race where we're passing off the baton from the outside of the cell to the receptor, to JAKs, to STATs, to all the way to the nucleus. So this is called signal transduction. So if we can inhibit this passing of the baton, if you will, by inhibiting JAK, then we can block this pathway and we can block inflammation within tissue, including psoriasis. So this shows you a whole slew of different cytokines. It's a little bit overwhelming. I'm going to take a big approach to it. And just to let you know that there's many cytokines and pro-inflammatory mediators on the outside, and they have many different types of cytokines as shown in the different colors here. And then within the cell, you see the JAKs there. The point I want to make here is that the JAKs bind in pairs. There are 4 JAK family members: JAK1, JAK2, JAK3, and TYK2. So those are the 4 JAK family members, and they can bind with themselves. As you see in blue here, you see a JAK2 binding to JAK2, or they can bind with another family member. So you can have JAK3 and JAK1, you can have TYK2 and JAK1. You have these various pairs that form on the inside of the cell, leading to different inflammation. So different pairs are associated with different cytokine signalings. If we look then at what's out there in terms of JAK inhibitors for the treatment of psoriatic disease, the first one that comes to mind, we all kind of know about this drug, is Tofacitinib. Tofacitinib has been on the market for quite some time for rheumatoid arthritis, psoriatic arthritis, and ulcerative colitis. It blocks JAK1 and JAK3. There was some positive efficacy data in phase 3 for Tofacitinib. However, the FDA did not approve the drug due to safety concerns. And so we don't see Tofa being used for psoriasis, but it is approved for psoriatic arthritis. And importantly, with this drug, we have some boxed warnings because of side effects that have been reported with Tofacitinib: serious infections, mortality, malignancy, and thrombosis. Now, if we look in the lower half of this table, we see more blockade of JAK1. You have Filgotinib, you have Upadacitinib. Upadacitinib, for example, is approved for rheumatoid arthritis, but it has not been studied in psoriasis. So there's a variety of things going on in JAK inhibition in psoriasis, but we don't have a JAK inhibitor as of yet for this disease. We have one for psoriatic arthritis, Tofacitinib, but we don't see selective JAK1s being approved yet for psoriasis. So the inhibition of JAK family members may directly and indirectly suppress the activity of multiple cytokines that play a role in the pathogenesis of psoriasis. The problems with inhibiting JAK1, 2, or 3 in psoriasis are associated with its safety. So when we inhibit those particular JAK family members, we can see increased risk for serious infections, including opportunistic infections, and a number of other issues that may occur when we inhibit JAK1, 2, or 3. Now this takes us to the main focus of the talk today, and that's TYK2. So this is the 4th member of the JAK family. So TYK2 is a member of the JAK family. Don't ask me why it's not JAK4. It's in the JAK family. It just happens to be named TYK2. So just think of it as a JAK family member. Now, in contrast to what I just told you with JAK1, 2, and 3, TYK2 signaling is involved in a fewer number of cytokines. And in particular, when we look at the cytokines that utilize TYK2 in its signaling, we see cytokines that are important for psoriasis pathogenesis, namely interleukin-23, the main one, interleukin-12, which could be playing a role as well, and then type 1 interferons are also involved in TYK2 signaling. And type 1 interferons, I didn't mention it, have been implicated in the initiation of psoriasis, those early stages of activation of plasmacytoid dendritic cells producing interferon 1 and kind of kicking off the psoriatic process. So my point here is that when we talk about this JAK family member, TYK2, we're talking about inhibiting in particular cytokines that play a role in psoriasis. So TYK2 and JAK2, that particular pair mediates downstream effects of IL-12 and IL-23. Again, to remind you, IL-12 stimulates Th1 T cells. IL-23 is the master cytokine for regulating control of Th17 cytokines. So if we can inhibit TYK2, we can inhibit IL-23 signaling. That's one of the key points for the lecture. So we also see TYK2 pairing with JAK1 to mediate signaling of interferon alpha and beta. We see them as early stage cytokines involved in dendritic cell maturation and activation, polarization of Th1 and Th17 cells, reduction and regulatory T cell function, which would be a bad thing in psoriasis, and increased activation of B cells associated with antibody production. So let's delve a little bit more into the rationale for inhibiting TYK2 in psoriasis. So I just gave you a lot of good reasons, right, of why we should block TYK2 in psoriasis, because it blocks IL-12 signaling, IL-23 signaling, type 1 interferon signaling. But there are very interesting genetic data suggesting that the TYK2 gene is a polymorphism associated with susceptibility of psoriasis. So the folks studying genetics of psoriasis have identified TYK2 as an important gene. And what we found is that if there is a loss of function polymorphism, so a genetic change that leads to kind of a poor functioning TYK2, that actually leads to defects in signaling for the cytokines that I mentioned, IL-12, IL-23, such. And what we see then is that those people that sort of have natural loss of function are relatively protected from developing psoriasis. So that's a really interesting kind of natural experiment, if you will, where the gene has been altered in some individuals and they're protected against psoriasis because they don't have a fully functioning TYK2. And we see it also with some other autoimmune diseases as well, so where TYK2 can play a role in those diseases. Now, for the most part, those patients still have some TYK2 functioning, but it's impaired. And because they have some, they actually do not show any risk for severe infections due to this genetic polymorphism. So that's another important point. Protected from psoriasis, yet not susceptible to a variety of infections. All right, so we are going to take a closer look at the evidence of inhibiting TYK2 in psoriasis. So I'm showing here an overview of agents that have been studied thus far. There's 3 listed here. The first one, deucravacitinib. The second one, Brepocitinib. And the third one is just a number right now. It's PF 068-26647. So these are all TYK2 inhibitors. They're mostly studied in oral formulation. One of the drugs, Brepocitinib, has also been studied in topical formulation. And they've been studied in both psoriasis for the most part and psoriatic arthritis. So if we look at this, the main point that I want to make here is that TYK2 has 2 domains. So I already told you that TYK2 binds to another pair, such as JAK1 or JAK2. But within TYK2, there's a regulatory domain and there's an active site domain. And most JAK inhibitors will block in the active site domain. The problem with that, if you have a JAK inhibitor binding there, is that there's overlap with the other JAKs. So there's some leakiness, if you will, for drugs that we say are JAK1 blockers. Well, they can also block to some extent JAK2 and JAK3, for example, because they block in this active domain that also inhibits these other types of JAKs. In the case of deucravacitinib, it's different. So for deucravacitinib, the drug blocks in the regulatory domain of the molecule. And what's important about that is if you block in that domain, you don't see cross-reactivity of blockade of JAK1, 2, or 3 when you're binding in the regulatory domain, like deucravacitinib does. When we look at in vitro assays, we see that it has no blocking activity whatsoever in the active domains of TYK2, of JAK1, JAK2, or JAK3. There is no leakiness, there's no cross reactivity, if you will. But then when we look at inhibition of the regulatory domain, that 0.2 number, we see very specific inhibition of TYK2 in that domain. That's what makes this particular drug, deucravacitinib, quite ideal and quite special compared to other JAK inhibitors in that it binds to this regulatory domain. And if we look at the signaling, the downstream effects and effects on IL-23, IL-12, interferon alpha signaling, for example, we see that the drug with low numbers here blocks the activity. So a lower cellular IC50 means that it blocks better. And we see quite effective blockade with IL-23 and interferon alpha in particular. So what I'm showing you now is some clinical trial data for deucravacitinib. Now here we're showing the phase 2 results, and this is PASI 75 at week 12 for deucravacitinib. And we see the result is 69% of patients achieving PASI 75 at week 12 in this phase 2 trial. In my view, this is the highest PASI 75 that we've seen with any kind of oral drug. And it's clearly, as you can see from historical context, it's not a head-to-head in this particular slide, but we can see historically it's much better than apremilast. So what I just showed you was the highlights of the phase 2 study, which was published several years ago for deucravacitinib. Now I would like to talk about the phase 3 results for deucravacitinib. So these are new results. They're phase 3 results that were just released at the AAD meeting in April. So if we first look at the design of the studies, we have two studies we're talking about now, Poetic PSO1 study and the Poetic PSO2 studies. They had a large number of patients. Between the two, there were over 1,600 patients in these two phase 3 studies. Both of them had apremilast comparators, and both of them had placebo comparator as well. Now, for the first 6 months, we see that in Poetic 1, it was deucravacitinib, 6 milligrams per day versus apremilast 30 milligrams BID. And then the patients on deucravacitinib stayed on that, and the patients who had not done well with apremilast were switched over to deucravacitinib, and those who did well with a PASI 50 or higher were kept on apremilast for 52 weeks. In Poetic 2, we have, again, the 6-month comparison between deucravacitinib and apremilast. And here we have all of the patients who were on apremilast going to either deucravacitinib or to placebo. So no one in the apremilast group continued on 52 weeks. So the 52-week comparison with apremilast in Poetic 1 and the 6-month comparison with apremilast in Poetic 2. If we look at the primary endpoint, so the primary endpoint is week 16, where we're looking at placebo versus apremilast versus deucravacitinib. And here the primary endpoint is PASI 75. And we see that in Poetic PSO1, 58.7% of patients achieve the primary endpoint versus 35.1% of patients on apremilast and 12.7% of patients on placebo. We switch over to Poetic PSO2. We see there are similar results. 53.6% of patients on deucravacitinib, 40.2% on apremilast, and 9.4% on placebo who are achieving this PASI 75 at week 16. Now, if we look at the co-primary endpoint, that's SPGA 0/1 response, again at week 16. We see the numbers are 53.6% for deucravacitinib in Poetic 1 and 50.3% in Poetic 2, and the apremilast comparisons are 32.1% in Poetic 1 and 34.3% in Poetic 2. So with both primary endpoints, EASI-75 and an SPGA 0/1, we see similar results with superiority of deucravacitinib over apremilast and over placebo. Now, there were ranking listings of other endpoints in these trials, and I'm showing that here. There were comparisons with placebo, and we see that deucravacitinib met the statistical significance for 7 of the 8 endpoints listed on the left, And then if we look at the ranked endpoints for apremilast on the right, there were 13 ranked endpoints, and we see that 12 of them were met with deucravacitinib versus apremilast. So what are some of the other endpoints? So PGA 01 at week 24, week 52 responses, and a number of PROs such as DLQI 01. Let's delve a little bit deeper on some of those secondary endpoints. So here I'm showing that patients with moderate to severe scalp psoriasis at baseline, what percentage of those patients achieve clear or almost clear scalp during the trial? And actually, it's 71.8% of deucravacitinib patients who had moderate to severe scalp psoriasis who go to clear or almost clear at week 24 versus 42.7% of apremilast patients. That's in Poetic 1. If we look at scalp response in Poetic 2, similar results, 59.7 versus 41.6. If we look at a PRO, in this case, we're looking at the PSSD symptom score. So it's a combination scoring system asking patients about their psoriasis symptoms. And what we're looking for is the drop in the score over time, which indicates more improvement in symptoms of psoriasis. And with deucravacitinib, we see they had a 31.9% drop in their score for their psoriasis symptoms versus 20.7% drop with apremilast. In Poetic 2, we see similar improvements in these symptoms, 29.1% drop with deucravacitinib versus 21.4% drop with apremilast. If we look at another key secondary endpoint, a PRO that we all know about is the Dermatology Life Quality Index. A response of 0.1 in this particular PR means that the patients have no impact of psoriasis on their quality of life. So this is the most ideal response that we see from patients. If they feel like their psoriasis has no effect in their life, they score a 0 or a 1. In Poetic 1, we see that 47.8% of patients achieve a DLQI of 0.1 at week 24 versus 24.2% of apremilast patients. And then similarly in Poetic SO2, 41.8% achieving that high level of quality of life improvement versus 21.5% of patients on apremilast. Now, turning to safety, we're going to first show the week 0 to week 16 safety summary. And the reason to present it this way is that we have the placebo control in this period. So we have the adverse events for placebo on the left, the adverse events for deucravacitinib in the center, and those for apremilast on the right. I'm not going to go through every number here. Suffice it to say that the numbers for both deucravacitinib and apremilast are actually similar to what we saw in the placebo-treated group. So, for example, the number of serious AEs in placebo was 2.9%, and deucravacitinib it was 1.8%, and apremilast 1.2%. So all very low in all three groups. If we look at common things, the most common thing was nasopharyngitis. It was 8.6% of patients on placebo, 9.0 for deucravacitinib, and 8.8 for apremilast. So you can get some idea here just how similar these reactions are. One thing that does stand out a little bit is that nausea was seen much more commonly with apremilast-treated patients, 10% of them versus 1.7% of patients on deucravacitinib. If we now look at week 0 to 52, we need to represent the data now in patient years. So number of events per 100 patient years is the way that this data is typically presented. So this is a rate. And we see, again, very promising things for deucravacitinib. If we look at the rate of, for example, all AEs, it's 229.2 events per 100 patient years for deucravacitinib, and it's 217.9 for placebo, and 281 for apremilast. Again, if we look at a common thing like nasopharyngitis, we see that the rate is 26.1 events per 100 patient years for deucravacitinib versus 22.9% for placebo, 25.9% for apremilast. Again, we see the nausea standing out here for apremilast in terms of week 0 to 52 safety data. Now, when we think about deucravacitinib, we know that TYK2 is a member of the JAK family, and so we want to look at AEs that have been associated with other JAK inhibitors. Now, as I've emphasized earlier in my talk, TYK2 is different than the other JAKs, and we would not expect to see some of the same things we see with other JAK inhibitors. Now, here I'm showing you a number of different things of interest for patients on any kind of JAK inhibitor. So we have non-melanoma skin cancer, malignancy, serious infections, herpes zoster, arterial thrombotic events, venous thrombotic events, and MACE. And what we're showing here is the estimated incidence rate per 100 patient years. And what we're seeing is that the rate for all of these items is low and in the range of placebo, which is nice. We see a little bit of elevation under the serious infection category for deucravacitinib. It's comparable, though, to the apremilast rate. And we see just overall low incidences of all of these particular AEs. If we now look at laboratory parameters that have been associated with other JAK inhibitors, things like cholesterol, CPK, neutrophils, and platelets, we actually see with deucravacitinib, just like what we see with placebo and apremilast, is that very stable lab numbers for all of these particular items. So we do not see drops in any of these blood counts, for example. We do not see cholesterol elevations. And again, this is important data because these are the data that we see, the things that we see with other types of JAK inhibitors. So we know that deucravacitinib inhibits TYK2. We know that TYK2 is involved in IL-12 and IL-23 pathways. We know that IL-23 is important for psoriasis, psoriatic arthritis, and inflammatory bowel disease. And so because of this, we're seeing TYK2 inhibitors like deucravacitinib being studied in these particular diseases. And what I'm showing you today really is significant in that it's the first phase 3 studies for a TYK2 inhibitor, deucravacitinib, for us to examine and consider as we think about this type of drug in our management of patients with psoriasis. What about psoriatic arthritis? So we haven't really talked too much about psoriatic arthritis, but what I'm showing you here are actually phase 2 results of deucravacitinib for psoriatic arthritis. And the main endpoint is going to be ACR 20. It's sort of like the PASI 50, and then we have ACR 50, ACR 70, which are more like the PASI 75 and PASI 90. So we see that patients on deucravacitinib do fairly well, actually, in ACR 20. With the highest dose, 62.7% of patients achieved ACR 20 at week 16. That's actually a very high number for a psoriatic arthritis trial. If we look at higher bars, ACR 50 and ACR 70, we also see responses in those areas. And again, we also see a dose response. We see the 12 milligram group once daily doing better than the 6 milligram daily group for this particular PSA trial. There are other efficacy endpoints shown at week 16. There's a variety of them. The bottom line here is that the drug works for psoriatic arthritis. We don't see as much of a dose response in these other endpoints, but we do see, for example, improvements in quality of life, in enthesitis resolution, two really important things for patients with psoriatic arthritis. So more to come in the field of psoriatic arthritis as well for this particular drug. I'm going to switch gears a little bit and talk about the other TYK2 blockers that are in development. So this is another drug called Brepocitinib, and I'm showing here some phase 2A results. It's a randomized double-blind placebo-controlled trial. And what we're seeing here are drops in the mean PASI going down basically with this particular drug. Again, there's a dose response here. There's increased response from week 4 to week 12 with this Brepocitinib agent. And we see the percentage of folks that are achieving a PGA response of clear or almost clear on the different doses of Brepocitinib. And so we clearly have another drug that works well in psoriasis in addition to deucravacitinib. So I just show you some promising efficacy results for Brepocidnab. Out of the 149 patients that were treated, 6 of them developed serious adverse events. And so This drug has actually been dropped from development, but we do see that a topical formulation of Brepocidnib is still going forward in mild to moderate psoriasis. And we also see that this drug orally is still moving forward in other types of diseases, including active psoriatic arthritis, ulcerative colitis, Crohn's disease, hidradenitis, and SLE. There's a third TYK2 inhibitor. This is the one without a name. It just has the number, PF068-26647. And this one, we just have had very recent results in the literature, just reported in the December issue of Lancet. This was a phase 1 randomized double-blind placebo-controlled trial in patients with plaque psoriasis. It's limited because it was a phase 1 trial, but there was significant improvement in psoriasis within 4 weeks of dosing with an acceptable safety profile. We do know that a phase 2 trial was undertook and actually recently completed, but we don't have results yet for this particular TYK2 blocker in the phase 2 trial. So when we look at the current treatment status for patients with moderate to severe psoriasis, we see that there are about 2.7 million of those patients. About 1.9 million of those patients are treated with topicals. Now, this is a challenging number for me and for others working in this field. We believe that there are far too many patients with moderate to severe disease being treated with topicals. We think this is problematic because of their limited efficacy, problems associated with long-term use, and the inability for these drugs to cover widespread lesions. Now, if we look at who are being treated with current oral therapies, it's about 400,000 of the 2.7 million, and many of those patients are on apremilast. As we have seen with this new phase 3 data, apremilast only has PASI 75 results in a 35 to 40% range. And that's what we saw in the original apremilast phase 3 studies, as well as in the head-to-head comparisons with deucravacitinib that I've just presented. So there's a lot of patients being treated with oral therapies. A lot of those are on apremilast. And then lastly, we have about 400,000 patients on biologics or injectables. We have incredible PASI 75, PASI 90, PASI 100 numbers with those drugs, but the problems are they can be hard to administer. Patients don't necessarily like shots. There are a lot of barriers in practice to getting biologic therapy. So really what we're seeing with deucravacitinib is the first new oral drug likely to be approved for psoriasis that fits a niche of treating a moderate to severe psoriatic who may not qualify for a biologic or may not want to get a biologic or may not be able to afford to get a biologic, who is looking for more efficacy than what we've seen with apremilast. Thank you very much for your attention.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/NJS860. This activity is supported through an educational grant from Bristol Myers Squibb. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education.